I'm Jason Jedlicka. I am a professor at Indiana University School of Optometry in Bloomington, Indiana. So today we're talking about scleral lenses. We're talking specifically about trying to help practitioners to be more efficient with the fitting process. Scleral lenses can be challenging for anyone to fit efficiently, trying to get the fit idealized. Particularly though in a health system in a country like the UK, where follow-up care is challenging to get patients back. We really want to focus on how do we get to an acceptable endpoint as quickly as possible with the least number of visits for the patient. When a scleral lens is fit properly, a patient will often say, I can't tell it's on my eye. And so they can be just as comfortable as a soft lens, but it requires getting them to fit properly. Even if you're not going to fit them, you should understand their application. We all have a lot of things our patients benefit from, surgical procedures or treatments that we don't do individually, but we know that they would benefit. We refer them. And so being able to understand when a scleral lens is appropriate, even if you're not going to fit it, is helpful. The other part of it, though, is scleral lenses can be very rewarding to practice. And there may be practitioners out there that could be doing it that aren't, if they just understand a little bit more of the hows and whys. The other part of it too is they've always had a bit of a niche with the irregular cornea and diseased eyes, and yet there's no reason they can't be worn by normal eyes just for refractive error. You know, again, for my patient who walks in who's a 3 diopter myope with no astigmatism, scleral lenses probably aren't really in the discussion. But for patients who come in who are, again, irregular corneas, ocular surface disease, symptomatic, and haven't found a good answer to their symptoms. And even the refractive error patient who struggles with conventional approaches to correcting their vision, whether it's traditional daily soft lenses, whether it's corneal GPs, but haven't found something that really gives them the quality of vision or comfort they're looking for, that needs to be part of the discussion. And if the patient says, I'm interested in that, and I don't fit it, then I need to find them a practitioner who will. Step one is to understand the impact of the corneal shape on our scleral lens fit. So the 4 steps we're talking about really involve making sure that we are really properly assessing the patient's eye that we're going to fit. Take the time to understand that eye carefully. Take the time to understand the lens that you're fitting and know how it works well. And then beyond that, we're talking about looking at the fit aspects, reinterpreting fluorescein patterns, which we've gotten away from a little bit in the recent years with scleral lenses, and how we're going to look more carefully at the edges to get the edges right. Again, all of which is to say we're going to try the best we can to get one and done. Maybe not realistic, but the least number of visits and reorders, the better. Okay, so that's one. Think about the cornea you're fitting. It does matter. Step 2, understand the impact of the corneal size. So optimizing a fit can happen a couple different ways, trial and error. Which is a laborious process, to say the least, especially if you're really going for an optimal fit. You can use instrumentation. So again, a scleral topographer. There are a variety of different brands out there that map the shape of the eye, cornea, limbus, sclera, the whole thing. And you can fit the lens with that information diagnostically, or you can now even order lenses that are map-based or impression-based that optimize the shape of the lens to the shape of the eye. It really comes down to, again, is maintaining a minimal acceptable tear layer under the lens, and maintaining a thin lens profile. And so we just want to be careful with our approach to fitting and make sure that we've done everything we can to keep the lens and the reservoir, both of those thicknesses, as low as possible, and that our lens material is also made of the most breathable materials. Okay, step 3, let's consider the shape of our eye at the lens landing point. So with a scleral lens, breathability is an issue. We are using hyper decay materials, but because of the thickness of the lens and the tear reservoir that's trapped underneath that lens, you are reducing oxygen permeability to hydrogel soft lens levels. But for a normal healthy eye, that's completely fine. For an eye that's not compromised endothelium, that's just fine. And there are ways we can go about making it more breathable by keeping the lens thickness down, by keeping the vault down, things like that. So for me, oxygen permeability is really only an issue when we're dealing with sick eyes, which are a number of our patients, but certainly not all. As far as infection and whatnot, I think that's actually something that's being looked at right now. There's a study ongoing, a retrospective on risk of microbial keratitis with scleral lenses. But in my experience, I haven't seen any increased risk of infection or other complications. Certainly, I think hypoxic changes, again, like vascularization, can be an issue. Corneal edema can be an issue. All those things need to be mitigated by optimizing the fits.
Okay. So finally, let's talk about the scleral shape itself. We've talked about everything so far is really all about the internal vaulting chamber. Let's move out to the scleral zone.
Historically, keratoconus was a sweet spot because of the irregular corneal shape. We're looking for better vision. Post-surgical eyes, patients who'd had surgery with complications or even just penetrating keratoplasty where they end up with a clear cornea but an irregularly shaped cornea. Those were your bread and butter patients for scleral lenses. Partly because corneal gas perms in some of those instances are hard to fit and be stable on the eye due to the unusual eye shape. Beyond that, though, we also found that scleral lenses have a great application for patients with ocular surface disease, particularly the moderate to advanced cases where the patients really, it's a life-altering experience. They're constantly aware of the discomfort that their eyes give them. Those patients are also great candidates for scleral lenses. Again, as we get more experience with fitting scleral lenses, we get better at it. As our techniques get better, as diagnostically we get better, as our lenses get better, we can bring that same comfort and vision to less sick eyes. Again, patients with just high refractive error that would benefit from the quality of a GP lens, but they don't want to wear a corneal GP because of comfort issues. So again, we can correct all the same conditions with a scleral as with any other lens and more. It's just becoming comfortable with the fitting process for those who don't need it as badly, but who maybe would want it just because, again, of the comfort and vision.